I'm happy to welcome you to this first Enrico Anglesio Prize Alumni Committee webinar. Today we will host our first webinar for this year, and hopefully there will be other opportunity also later on. Today I had the great pleasure to have two very relevant speakers, the winner of the 2023 Enrico Anglesio Prize, Alice Bernasconi from Fondazione IRCCS, Istituto Nazionale dei Tumori from Milan, Italy, with a presentation on artificial intelligence and cancer registry data to predict rare events in cancer survivors, and the winner of the Elvo Tempia Special Prize 2023, Giulia Capitoli from Bicocca Bioinformatics, Biostatistics and Bioimaging Center of the University of Milano Bicocca, again from Milan, with a presentation on complete blood count test in children and adolescents with Trisomy 21, definition of syndrome-specific reference intervals to detect evolution into onco-hematologic pathology. These two speakers have won the prize, and the prize was awarded in Granada last November. So now I'm happy to give the floor to Alice. Please feel free to share your screen with the presentation.
First of all, I want to thank Lydia for introducing me and the other winner, Giulia, and the reviewer for selecting this work as winner of the Enrico Anglesio Prize. It is an honor to be here today with you. I just very quickly introduce myself. I am a researcher, an epidemiologist at the Istituto Nazionale dei Tumori in Milan, and I am also a PhD student in computer science at University of Milano Bicocca. This work I'm presenting today is part of my PhD project, and it aims at predicting rare events in cancer survivors, taking advantage of artificial intelligence methods and cancer registry data, with a very specific research question on cardiovascular risk in adolescents and young adults surviving breast cancer. To give you a little bit overview of the background, adolescents and young adults are those patients aged 15 to 39 years at first cancer diagnosis. The tumor case mix is in this wide age class is very heterogeneous. These patients share tumors both with younger and older patients, but with a very peculiar tracks in terms of biology. Like in older women, breast cancer is the most frequent tumor in adolescents and young adults females. However, there is a survival gap between these two age classes. This is due to a more aggressive biological case mix that results in higher tumor grading and low response to molecular target treatments. The aggressiveness of this tumor often requires more intensive treatments and doses in adolescents and young adults with breast cancer. Most of these treatments, however, comes with cardiotoxic effects. Let's think about anthracyclines or off-target therapy. So even though cardiovascular diseases are rare in this age class, these patients are at higher risk of developing them. We all work in the oncological field, so you will already know that one of the main issues for oncologists is patients' follow-up after treatment ending. In this context, the follow-up guidelines target for adolescents and young adults are essential to prevent cardiovascular diseases in this age class. And AI can really help clinicians in this task. In the literature, many models exist to predict cardiovascular risk in cancer survivors, but with many limitations. We can sum them up in few points, I think. The data availability and scarcity, the computational burden and skills needed to handle them, the lack of interpretability and generalizability, And last but not least, I think the absence of the causal interpretation of the model and its result. All these limitations makes the clinician reluctant at using the actually available AI tools for cardiovascular risk prediction in their everyday practice. In this context, we aim at developing a causal network-based model for estimating the risk of cardiovascular diseases in adolescents and young adults surviving breast cancer. But before going deeper into the methods, we need to better describe the data we have. To build our model, we made use of two different cohorts of patients, a population-based cohort and a clinical cohort. Both of these cohorts have pros and cons. The population-based cohort is a wide cohort, unbiased, and able to track cardiovascular events because cancer registries can link to the patient also administrative data sources. However, unfortunately, this cohort is poor in terms of clinical details, being based, as I said, on cancer registry data. On the other hand, we have a clinical cohort that is very rich in terms of cancer prognostic factors, but has two main limitations. The selection bias, because being this a one hospital only based cohort, it is selected by default. And also there is this inability to track the cardiovascular events because oncologists may lose the patient during the follow-up. So the integration, the piercing of these two cohorts is fundamental to build a causal model. Here you can see the details of the two cohorts. We have more than 100 patients in the population-based cohort and about 300 patients in the clinical cohort. The selection bias I mentioned before is evident when you have a look at the treatment distribution. In fact, in the clinical cohort, we observe more neoadjuvant treatments that reflects more severe cases at diagnosis. There is also a higher proportion of baseline cardiovascular risk factors, as you can see. So the problem is complex. We want to piece together data from two different cohorts and build an interpretable model. That's why we choose to focus on probabilistic graphical models. These models this is a class of models based on causal diagrams that allows to make assumption explicit and give a clear interpretation of the results. Within this class of models, Bayesian networks, thanks to their ability to split complex graphs using conditional independencies, are very good at dealing with low numbers and integrate clinical knowledge. Very quickly, here's how we proceed for the analysis. The overall sample, as I said, was composed by the two cohorts. And we partitioned the entire sample into a training and a validation set, test set, we can say. The clinical cohort did not collect information on the outcome. Sorry, okay, working. So it can contribute only to the training phase. In the training phase, while the population-based cohort contributed also to the test phase. In the training phase, we built a first version of the model using clinical expertise and scientific literature. Then we applied to the data a causal discovery algorithm, and we estimated the model parameters. Subsequently, we validated the model performances in the test set. So, to evaluate the model performances, we used two different approaches. We evaluated the model ability to prioritizing those patients at higher risk using the cumulative gain chart. That is a chart, the graph used in finance mainly. In the x-axis, you order the patient according to their predicted risk of developing an event, descending. The corresponding proportion of patients that really develop the event is plotted then in the y-axis. The faster the curve rise, the better the model is at predicting the events. Moreover, we also compared the model results with those obtained using the most commonly used machine learning approaches using standard metrics classification mainly. So this is our model, the model we start from. You can see the arcs we derived from the domain knowledge. Once we applied the causal discovery algorithm, we obtained additional arcs that are highlighted in blue in this slide. For those of you interested in the model structure, I will leave a link at the end of the presentation, or you can contact me or ask for more details, but I cannot describe it now. Let's go to the cumulative gain chart. As I previously said, the x-axis contains the proportion of patients observed, ordered descending by their risk of developing a cardiovascular disease. The risk is estimated using the model. You can see that the curve rises very fast. For example, if we focus on the first quartile of the patients, the 25% of patients with the highest risk according to what predicted by the model, we can identify about 80% of those that will really develop the cardiovascular disease. To go to the classification performances, according to all the standard classification metrics, our model showed very good performances, never lower than those observed in using other standard machine learning models. The difference here is that while in our model, we can use both scores to train and validate the results, in the machine learning approaches, we used multiple imputation. That is a big limitation because it comes with lots of assumptions. So, to sum it up and try to conclude, in this work, we defined the first causal model for the prediction of cardiovascular diseases in AYA with breast cancer, piecing also together population-based and clinical data. The causal discovery algorithm not only improved the model performances, but open medical insights, particularly valuable for such an understudied population, such as AYA. The model showed also good performances, both at prioritizing those patients at higher risk and also in terms of classification. But the most important thing is also that it provides interpretable results thanks to its structure. Next steps, we are working on the development of a desktop-based app and on the causal estimation of the effects. This is an example of how the app may look like. We are still working on it. To conclude, this is a very practical use case, but it showed the relevance of cancer registries data for studying and preventing late effects in cancer survival. So I think it can be very interesting to apply also these methodologies to other research questions. For those of you interested, I leave here a QR code with the link to download the methodological paper with the detailed description of the nodes, the arcs, the structure of the model, how we build it, and so on. And of course, I'm here if you have any question. Thank you very much for the attention.
Thank you, Alice, for your presentation. I think it's a very nice work. Thank you very much for presenting it. And I have missed one thing. So one important thing of your model is that the interpretability. But one of the limitation of AI model is actually that it's often perceived as black boxes. I didn't get where is, or I probably missed in your presentation, where is the interpretation, or what you mean with interpretability of the results? It's just
no. It's essential. That's the most important part of our model. Probably, if I share with you the model, it's more evident because I did it very quickly. But this is the actual structure of our model, where all the arcs describe a causal relation across two nodes. So, for example, here you can depict the relations between neoadjuvant treatments, surgery, adjuvant treatments, and their role on cardiotoxicity and ischemic heart diseases. The next step of this work is to estimate the impact of each node in numerically speaking, so that you can better understand which are the relationship and intervene on this relationship in order to prevent cardiovascular diseases. For example, what we observed since now is that it seems that the neoadjuvant treatments are those mainly related to cardiotoxicity. That is something that needs more investigation, because it is probably due to the different schemes, doses, and so on. But it's something interesting. It is something you can give to a clinician and they can understand it.
Thank you very much. So you identify some of these factors that are more relevant with respect to the disease and the study.
Exactly.
Thank you so much.
Thank you.
Hi, Alice. Thank you very much for your presentation. It was very interesting, and I wanted to listen to it in particular because we are starting a work with some clinicians that are interested in glioma tumors. And, in the context of these tumors, we do have a rare event, which is surviving more than just, a couple of years. My question is, did you force sort of your modeling to produce results that are interpretable? Or did this happen, just because it happened this way?
No, there were two phases to build the model. We started building the model according to what we know, according to the literature. So the first part of the model, the one in black, is decided according to what we know. We are sure this connection exists, even though we cannot estimate them. Probably it may happen because of the numbers, for sure. But we forced these cause-effect relationships because we know they're real. It can be used also to clean the selection bias in some cases, or the confounding bias in your data. The additional arcs are, on the contrary, estimated using the data. So this is something we did not expect according to the literature, or we may expect, but we were not that confident. But the data suggested them.
Okay. Now I understand. It makes sense. So you imposed some constraints that you know that exists, so then it doesn't. Okay, thank you.
Thank you.
Okay, we can maybe switch to Julia's presentation, and of course, if some other question come your mind, we can also continue later on. So Julia, the floor is yours.
Thank you, Lydia. So I will share my screen. I'm Giulia from the University of Milano Bicocca, And I studied math in a master as a master student, and then I graduated with my PhD in public health in biostatistical and clinical research in University of Milano Bicocca. Then I continued to remain there with my postdoc. And I work with clinicians and also try to develop statistical methods that can help clinicians in understanding the data and try to respond to their questions. I work with the Bicocca Bioinformatics, Biostatistics and Bioimaging V4 Center of Milano Bicocca. We are in Bicocca is divided from Monza and Milano, that are two different cities of Lombardy, and we are in Monza because we work with the hospital that give us all this type of data. So I will present this work. This work wanted to understand the reference intervals for healthy children and adolescents with trisomy 21. In this sense, if we are able to identify the normal parameters, we are also able to identify some complete blood count tests that maybe are identifying some pathological risk. And so Down syndrome is a very frequent syndrome in childhood and have an increased risk of different factors during childhood and adolescent, like onco-hematology disease, and increase 50 times the risk to have acute leukemia and myeloid leukemia and also lymphoblastic leukemia. That are 3 different types of onco-hematology disease. And so the American Academy of Pediatrics recommends a complete blood count test to be performed at birth every 3 months after during the first years of life, and then to perform it each year. And in this moment, to date, reference range of normality of these tests are only be used for the general population, and so it cannot be applied to patients with Down syndrome. There are only 2 recent studies that describe reference interval in children with Down syndrome, but are not for reference population of Caucasian people, because are 2 studies, one for non-Caucasian ethnicity and another ones for the Mexican North American population. So these only 2 studies pose our research question, that is, we want to be able to identify reference range for complete blood count cell parameters for our specific population, that is for Down syndrome population in childhood and adolescent. And we want to divide them by sex and to create a reference interval for all the age from 0 to 18 years. And so how we enrolled our patients to have a huge amount of data, we decided to take both on a retrospective and a prospective view. So we take information that we have of patients enrolled in the archival records of our hospital from 1992, and we also enrolled new patients, and we follow until the last years if we have the possibility for all the teen years. And we exclude patients that have other counterfactual like heart disease, onco-hematology disease, chronic lung disease, and also the tests that were performed during the infection event or during surgery, or if they are taking some drugs. This because we want to create this reference interval for specific for this population in an healthy control state. And then this will pose the basis to identify if there are some characteristics that suppose that you are developing some onco-hematology disease. And so we started with over 6,000 of different tests from more than 500 of patients. And with the excluding criteria, we arrived to 3,000 of tests for 481 patients. And here we have a brief descriptive analysis of our data. We are a 50% of female and male, a more percentage of Caucasian people, because we are interested to create this reference interval for our population. There can be Down syndrome can have different genotypes, so the most common is trisomy 21, but can be also other type of genotype syndrome. And we have some comorbidities that these patients have in a very low percentage incidence of our population, but that's not great problem with the count blood cell test. And so they are not confounding factors in this reference interval. And so how we decided? We decided to, during the fact that we take patients from 1992, so this type of data, during the years, the laboratory instrumentation changed, and so we have half of the tests performed with laboratory instrumentation and the other half with new ones. And so we had forced to decide to understand if the reference intervals can be affected, can be method specific, and so we compare the temporal trends divided for these two types of instrumentation. We examined by a non-parametric regression analysis using cubic spline to ensure if we can have measures that are equivalent between the two methods, and so that we can use all this data for the different tests to create a reference interval. And also, once we create also our reference interval, we also compared with the two papers that I told you before, that there are only two that study this reference interval for Down syndrome patients. And we compare them, seeing that there are some differences based on ethnicity, but as we expected. And so this is some of the results. We create a reference interval. Here I report only red blood count cell, hemoglobin, and hematochricity, and palatal cell. And we create this reference interval using regression quantile, and we put some constraint on monotonicity and not crossing of the different centiles when we construct this reference interval. And we use also penalized spline to employed to model the nonlinear growth patterns concerning the age. We divide between female and male because, as you can see, the reference interval can change a lot. And looking at these brief results, you can see that at birth, infants have high level of this hematological data, and this is due to the low oxygen present intrauterinally. Then, in the first week of life, this value decrease because there is this transition between intrauterinally and between a more higher oxygen environment after birth. And it after a tenfold of collapsing first phase, we have again a gradual increase. And during puberty is the times in which you can see more differences between female and male. This is done to the adolescent, so we have higher values in male sex due to testosterone, and conversely a reduction in female caused by menstruation. And so this is the reason that we not only want to create a reference interval based on the age, but also based on sex. And in order to support clinicians, we studied different count blood cell tests, like 8 different tests, and so I create a Shiny app to support clinicians in the study and in the making decision follow-up of their patients. And I don't know, but it may be work. This is the app that I create in collaboration with clinicians, because I ask them what they need. And so we create an app in when you can decide your gender, like female and male, your date of birth, and then you can insert different time point of your visit and the different value of the 8 different blood count cell tests. And you will have a summary of all your tests, and then you have a different page for all the different tests, and you can insert, like I will show you some data. You will find that at the time of your visit, so from your birth, your age, you will have your value at this time visit, and then if we insert after 6 months another value, we can see how change during time, and so during your follow-up the levels of your blood parameters. In this case it is hemoglobin, and in this sense clinicians can be supported to be able to see during time how these parameters change. And if you are reaching some lower percentile or upper percentile, that maybe can suppose that you are you are developing some problems with related to counsel. And so we evaluate the trends of patients, both healthy, but also we evaluate the ones that we excluded because they develop some oncological disease. And we see that the main one parameters that describe an alteration in this test is the platelet value. And so we suppose that maybe this must be studied more because maybe it can be like a parameters that can give us some more details on the developing of oncological disease in a previous state before you really see that you have this pathology. And it is a parameters that is poorly described in literature, and so maybe it's something that we want to discuss more with clinicians and their role and enlarge our cohort. And so the strength of this study is that is one of the widest course on pediatric adolescent patients with Down syndrome in Italy, and we identify new syndrome-specific reference interval that can be used, and we also support clinicians with an app. And we also compare this with the normal population, and we see that we are able to better identify the reference interval with patients with Down syndrome. And the problem is that we have a great variability between patients, between data, between the laboratory and the different instrumentation. And so maybe if we want to enlarge our cohort, maybe asking to create this study in a multicentric view, but we will must think how to control for this counterfactual problem. And in conclusion, so we were able to construct the reference interval and to see which are the most important parameters that maybe can indicate an increased risk on onco-hematological disease. And we support clinicians with our app, and at the moment we are trying to enroll multicentric other center from Italy to enlarge the cohort. And I want, okay. This, oh no, I wanted to, okay, stop. I wanted to thank the clinicians, that without their data, I cannot be enrolled in this study, and and also all the clinical students that work on this hospital with which I work. And so thank you to listen to me. And
thank you very much, Julia. Is there anyone with comments or questions? Maybe I can start and then someone else maybe has something to add. It's super interesting. Thank you very much for presenting this. So you have developed this Shiny Hub and you have identified 8, if I'm correct,
yes,
value that could be relevant. Have you or will you think about the combination of some of these parameters? I'm not an expert on this, but I'm work with biomarkers and also oncological biomarker. And sometimes the single one is not enough, but combination of biomarker could be useful. So I was wondering if there is something in this direction that you can maybe, that you have think about or that you can maybe explore in the future.
yes, yes.
Also too complicated from a statistical point of view to develop these things. Of course, I'm not going into this.
No, we are thinking about this. Yes, the problem is that working with quantile regression, considering the multiple variables at the same time, create, in this case, problem, and we have to understand how to solve it. It is a future work because we don't have at each time visit all the different parameters. So we have a lot of different we have a lot of we have a lot of NA value and so missing data, and because when we record this data from our archive of the hospital, not all patients perform all the tests, but and so we have to enroll, try to be able to create this analysis. We decided to take all the possible information that we have. So if a patient have only data on hemoglobin, we decide to retain it in the analysis to increase the number of these evaluation in hemoglobin state. But there are some parameters that have a lack of information, and so maybe we have to decide or to do an analysis on a subgroup of patients in which we have all the information and start to create these quantile regressions using data that are complete, or maybe decided to enroll new patients in which we say, okay, in a prospective view, we decided to take all the possible informations and so in this sense eliminating some missing data that can create problems in this moment.
Yeah, I can imagine, and actually I don't think that maybe a model with all the parameters would be really then useful from the clinician point of view, but maybe combination of some of them would be interesting. But of course I can also imagine that you can have problem with missing data, and also that it's already difficult to work with the cohort that you worked with, because you mentioned that it's the largest one, and I have no difficulties to imagine this, because it's in any case already a subgroup of the general population by age and for the disease and all the exclusion criteria that you put in place. So for sure, it's better probably to have a larger group than combining really different parameters. But maybe this would also be something. But thank you.
We are also interesting to understand. We want to ask to our clinicians are asking to other centers, because we want to understand if we don't think so, because given the fact that we have data from 1992 and the instrumentation change, we also look if this model can be instrumentation specific. But the problem is that changing maybe the hospital, there are other different instrumentations, and so maybe these we had also to check if other center have the same instrumentation that we have, and if this reference interval works with all the instrumentation. And so yes, to enlarge the court, we have to be sure that there are no confounding factors between a different center, but we can combine all the data together to not create like not reliable reference interval.
Thank you very much. Someone else with comments or questions?
I have just two questions, if I can. Thank you very much,
Yes.
Giulia. You mentioned that you observed the sex differences, but also before puberty?
Oh no, before puberty,
Oh,
they
okay.
are quite the same. We
Okay.
decided, in fact, in this, I didn't tell in this slide, but until the puberty, we retain all the data together
Okay.
to create the reference interval, and we split and create two reference interval difference by sex only from puberty to 18 years. And then when I had to report, I divided between female and male, but the construction until puberty is the same between the different sex. Sorry.
Okay. Sorry, just one more question, very quick. How much different are your reference value compared to those of the general population?
Oh, not for all the different parameters, but there are, yes, I don't have here, but we test them for some parameters, maybe with Down syndrome reference interval are like over the 90 percentile of the standard population. And so in that cases, for all the Down syndrome patients, you will say that maybe you are an increased risk, but it's not true because the reference interval starting from the 90 percentage of the standard population. So not for all the 8 parameters, but there are some one in which we saw a very high differences. That is a differences that clinicians already take in account in their clinical workflow. So clinicians don't look to reference interval of the reference population, but know that there are these differences in standard value. And so they say, okay, we know, but maybe it can be useful for all the different centers to have a reference interval. And so in this sense, we decided to create this one. But yes, it is something that clinicians for the expertise already know, and they usually use to not look to the reference interval of healthy population, normal population, but yes, to create something that is that can be used to all the different centers. It can be useful for all.
Thank you very much.
Any other comments? Questions?
Hello.
Hi.
Oh, hi.
Hi, Giulia and Alice. Hello, Lydia. I have a question. First of all, I want to congratulate Alice and Giulia for these valuable works and presentations and for the prizes. I have a question to Giulia. If I understood well, you mentioned that a low platelet count was a predictive factor of developing acute myeloid leukemia in Down syndrome patients. That means that in your retrospective cohort, you had some cases of myeloid leukemia.
Yes, is the cases that we eliminated from this court with which we create a reference interval because they came from the exclusion criteria. So with exclusion criteria, we eliminated all the patients that develop a leukemia state, an oncological disease, and we see that a progressive decrease is one of the most significantly altered the parameters, the platelet value, before the evolution into myeloid leukemia using this. So we created the reference interval for all the population, and then we use patients that were excluded by exclusion criteria to see how their behavior based on this reference interval, and we see that sure, they are not in the reference interval, but they started to be in the lower quartile or in the upper quartile. And so from that, we understand that maybe this can be something that can be studied more to understand if we are able in some sense to make a connection between the follow-up of the patients, so the trend of these different parameters, and to associate the trend to an oncological state. But we have not so much patients. So we have patients, but we need to enforce our analysis enrolling patients that develop oncological disease and to see how their behavior respect the reference interval.
Okay. The diagnosis was confirmed. That means
yes, these patients were
NFL.
confirmed, yes, by a diagnostic.
Okay, they were excluded a posteriori also.
Yes.
Also.
It's only patients that were enrolled a lot of time ago, they developed the disease, and so we know that they developed disease, and we use them to see how was their behavior before the development, because we have data from our archive of the hospital, and so we look at their trend to see if they really have some trend different respect to the normal ones.
Okay, thank you very much, Julia.
Any other question, comments? Okay, so I would like to thank again the two speakers for having presented their work today with us. I would like to remind you that this webinar has been recorded, so hopefully will be posted online on the YouTube channel of the Fondo Elena Moroni at a certain point, after some probably processing of the video, just to make it a bit more shorter or appealing. I just would like to share with you very few news from the cabinet, the alumni committee cabinet. As you maybe know, there is this alumni committee LinkedIn group. It's a group on invitation only, by invitation only, but we will be very happy to include you in the group if you are not yet there. So feel free to reach out using the alumni email address to ask to be added. Of course, you need to have a LinkedIn profile and then to be connected to me or someone else. But yeah, we will be happy to enlarge the group. The group has been created to increase visibility, exchange, and interaction among alumni. And we will also advertise their job position, interesting conference, interesting papers, and really the idea is to use this LinkedIn group to share knowledge and to also enlarge our network. There is a survey that was launched last year, more or less, to investigate the interest of the alumni and to obtain some feedback. If you have not yet done, please scan the QR code here and fill in the survey. It's still open, and we are really looking forward to having feedback from the alumni to have some more idea on how to what activities could be of more interest, how we should organize, things to have a larger audience and so on. This year, probably before summer, there will be the election round for the alumni cabinet, committee cabinet, and for the renewal or confirmation of current members. But of course, we will be also happy. We are more than happy to have new candidacy. So you are more than welcome to reach out via email again and to show your willingness to be part of the cabinet. And I think that this was the last. Yes, this was my last news that I want to tell you. To remain informed on the activities of the Fondo Elena Moroni and also to be updated on the next round of the Enrico Anglesio Prize, check always the Fondo Elena Moroni website. There is also an alumni page, and there we will also post a short summary of today's webinar. And after receiving the consent from the speaker, I will maybe also share the slide. There is, as mentioned, a YouTube channel, and there are already some content there, and you can subscribe the page to be informed when new content will appear. That's all. We also are almost on time. Thank you very much again for your attendance. Yeah, it was really great to listen to you. Congratulations again to the two presenters. And yes, someone is saying something?
No, I was only say thank you.
Okay.
Also to you, but I don't know if I'm the one that is speaking when you ask now. So I don't know.
Oh, you are more. It was really. I think it was really great to listen to you. So thank you again. And I think.
Thank you.
Okay, and so yes, it's also nice to see that different people from different continents were able to join us today, and hopefully next time we will be even more. This is always one of the aims of the committee, to try to enlarge our audience. But it was really nice to be with you for this hour. So see you soon. Bye.
Thank you very much.
Thank
Bye.
you.
Thank you. Bye.